Hello everybody. Today's topic is guidelines on the use of corticosteroid in critically ill patient with sepsis, acute respiratory distress syndrome, and community acquired pneumonia. These are the focus update which is released in 2024. So the corticosteroids in sepsis and septic shock recommendations are the panel suggests administering corticosteroid to adult patient with septic shock. It has a conditional recommendation and the low certainty. Panel suggests against the administration of high dose, short duration of the corticosteroid, which is defined as more than 400 mg per day of hydrocortisone, equivalent. Equivalent for less than 3 days for adult patient with septic shock, and it has a strong recommendation in the moderate certainty. So most studies included patients with septic shock and had showed small to moderate desirable effects. Although there was a only small reduction in mortality with a low to moderate certain evidence, there was a larger reduction in the shock reversal and the organ dysfunction with high certainty evidence. The panel felt that given the high prevalence of septic shock worldwide, even a small reduction in mortality can have large effect, and that the reduction in the shock reversal and organ dysfunction can have important implications in resource utilization. The panel did not make specific recommendation regarding corticosteroid regimen, but recommended against the use of high dose short duration corticosteroid given the risk of adverse effect. The panel did not make specific recommendation on sepsis without shock. If patient present with sepsis with severe community acquired pneumonia and sepsis with ARDS, then a panel suggests administering corticosteroid. Now the corticosteroid in ARDS. Now the recommendations are the panel suggests administering corticosteroid to adult critically ill patient with ARDS. It has conditional recommendation and moderate certainty. Now, the rationale behind this is corticosteroids provide the moderate desirable effect driven primarily by the moderate certainty evidence that reduce the hospital mortality. This effect is more pronounced when corticosteroids are given for more than 7 days. However, the ideal corticosteroid dose, timing, and the type remains unknown and left up to clinicians' comfort and other considerations. This is contrast to the previous recommendation in 2017 that suggested that methylprednisolone should be administered in 1 mg per kg within 14 days of diagnosis of ARDS. However, corticosteroid use was deemed feasible and acceptable to a healthcare provider. Overall, panel felt that the benefit of the corticosteroid use outweighed its risk. Now, the corticosteroid in community-acquired pneumonia. The panel recommended administering corticosteroid for adult patients hospitalized with severe bacterial community-acquired pneumonia. It has a strong recommendation and moderate certainty. Corticosteroid provides the large desirable effect in severe CAP with moderate certainty evidence, indicating a decrease in hospital mortality and need for the invasive mechanical ventilation. So, same mortality benefit is not seen in patient with the less severe community acquired pneumonia. Thank you.